Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adewuya. Today I am joined by Dr. Zakia Rahman, who is a clinical professor of dermatology at Stanford University and director of the Resident Laser and Aesthetic Clinic. She is affiliate faculty at the Stanford Center on Longevity and also serves as assistant chief and co-director of dermatologic surgery at the Livermore Division of the VA Palo Alto Healthcare System. Due to her commitment to advancing precision and inclusivity in dermatologic care, she has helped pioneer lasers and energy-based devices for skin of color through leading scientific advisory boards on multiple aesthetic medical device companies. Dr. Rahman is an invited lecturer nationally and internationally on skin of color, skin longevity, laser and aesthetic dermatologic surgery, social media beauty ideals, and physician burnout and wellness. She is a media expert and has been featured in the New York Times, Bloomberg News, Huffington Post, NBC, CBS, and Scientific American. She serves in the American Medical Association AI Subspecialty Collaborative and on the National Board of Directors for the American Society for Laser Medicine and Surgery. Her numerous awards include the Melanie Grossman Award for Leadership, Mentorship, and Advocacy for Women in Medical Sciences, as well as the American Academy of Dermatology Presidential Citation for Advancing Diversity in the Field of Dermatology. Dr. Rahman, thank you for being here.
Thank you, Dr. Adewuya, for having me.
You have been at the forefront of laser dermatology, equity, and care. I'm curious to hear from you what initially drew you to this intersection of science, aesthetics, and advocacy.
I credit my parents for a lot of who I am today, particularly in instilling service as a core value really early on in my life. Growing up, I did a lot of volunteering. My parents sent me to a local senior citizen center where I worked creating meals for Meals on Wheels. So I got to get an interest and realize how much value senior citizens have in our lives. Early on in my dermatology training, one of my attendings asked me to be involved in a clinical study on a condition called pseudofolliculitis barbae, using lasers with an extended pulse width to safely treat those patients. That was an aha moment for me that sealed my love of lasers and also in being able to use technology to treat everybody safely. Dermatology is the one specialty where it's so obvious because you have to go through the skin. As physicians, we take the oath to beneficence and non-malfeasance. The different phenotypes that we see in skin, hair, and nails, for me, how important it was to be able to treat my patients safely and effectively.
It's clear how deeply your personal values and upbringing have influenced your work. That intersection of service, scientific curiosity, and strong sense of advocacy comes through so clearly. And it's striking that even early on, you saw dermatology as a field of innovation, but also as a space where real disparities could be addressed through meaningful clinical work. That makes me want to zoom out a bit. Dermatology is evolving quickly, technologically, socially, and clinically. From your perspective, what do you think has changed the most in the last decade, and what still hasn't changed enough?
One of the things that has changed the most is the expansion of smartphone use throughout the world. As of April 2025, 70.7% of the world's population, or 5.81 billion, have smartphones. These phones that have photos in them. And we know that 3.2 billion images are uploaded every single day. That's about 1.1 trillion a year. And that number is expected to go to 2.2 trillion just by the end of this decade. There's no organ that's more imaged than the skin. We see our own skin, we see other people's skin all the time, and that affects a lot of things, including our sense of self-worth, but how we evaluate other people's, mostly in their sense of vitality. Often people thought dermatology is a vanity field, but it isn't. I like to use a different V word, which is vitality, because we know that how people view us affects things like if we're intelligent, if they view that we're guilty or innocent on jury trials. People wanting their skin to look the best has even become more at the forefront. Dermatology is also a field where, because of these images, use of artificial and augmented intelligence is something that we can do in skin cancer diagnosis and in the diagnosis and treatment of disease. That gets me to where we haven't gone enough, which are these disparities. We still see major disparities in diagnosis and treatment of skin ailments because how light reflects on the skin affects how we're able to diagnose things like pigmentary disorders, melanoma, which we know that there's differences in morbidity and mortality at diagnosis. So I think that there's a lot more opportunity where we haven't gone far enough.
The distinction you made in saying dermatology as a field of vitality rather than vanity is especially resonant today. Visibility has clinical implications. We know appearance related concerns can influence everything from mental health to how others assess credibility or competence. At the same time, the expansion of tools like AI raises the stakes for accuracy, especially given the visual nature of this specialty. Foundational disparities still persist, particularly in how skin conditions are diagnosed across different skin tones. What recent advances in laser technology do you think have truly changed the game, not just in improving outcomes, but in shifting how we think about treatment itself?
Talking about this idea of vitality in dermatology, think of lasers and light based technologies and energy based devices as just another tool. Lasers change the game in terms of being able to effectively and safely treat people. One is the advent of fractional lasers that improve the access of people who could safely and effectively get laser treatments for conditions like pigmentary disorders or acne and acne scarring, which we know has different incidence and prevalence depending on your racial background. I still, to this day, see a lot of people for complications of laser based technologies that they've had, people who have permanent loss of pigmentation with lasers that don't incorporate those new features like fractional lasers. When you look at traditional lasers that were targeted at water, they basically would be able to treat things like wrinkles or photo damage or acne scarring, and they would treat 100% of the skin. That would mean that you're dependent on the pilosebaceous units as well as the stem cells and the edges of the wound to reepithelialize. That reepithelialization took anywhere from 7 to 10 days in ideal wound conditions, which we know patients often will have a hard time doing at home. When you look at fractional lasers, that gets reduced because you have these small microscopic areas where you either ablate or coagulate tissue. You can quickly heal that skin from the wound edges, which reduces that risk of permanent loss of pigment or hyperpigmentation, which is often when you break that epidermal dermal barrier, you get pigment dropout and you can get hyperpigmentation in all people, but particularly those of us who have more pigmentation in our skin.
The way you describe lasers as part of an expanded toolkit and as biologically active tools with broad clinical utility underscores how the field is evolving. As these technologies grow more sophisticated, the convergence between cosmetic and medical dermatology seems to become more apparent for clinicians outside of academic centers. That raises a question about access, not just to equipment, but to training. How accessible is this kind of laser technology to the broader medical community? And what role does education play in ensuring its used safely and equitably?
That goes to access, which is a major issue in healthcare all around. Dermatologists are 1.2% of physicians. The average wait time, at least throughout the country, is about 38 days, but it can range up to months. For our clinic, which focuses on lasers and energy based devices and aesthetics, the wait time is multiple months. So I think it is hard to have access, but we are involved with education through our National American Academy of Dermatology and the American Society for Laser Medicine and Surgery, which I sit on the board of providing education. If people are interested in getting more education, I'd recommend that they go to these conferences or take online courses. There is more and more information available, which particularly for those of us who are healthcare providers, will allow us to deliver better care.
This gets to a broader issue. Even when technology is available, it doesn't guarantee equitable care. Many patients, myself included, struggle to find dermatologists who are trained to care for richly pigmented skin. And it's not about racial identity per se, but about clinical familiarity and diagnostic precision. Are efforts to diversify training and clinical competency being meaningfully integrated into national dermatology education? And what impact do you think this is having on both patient care and workforce representation?
These personal stories matter a lot. They're what matter to us as physicians when we deliver care. I think specifically with the American Academy of Dermatology, they recognize the need to improve clinical competency for treatment of people of color, particularly as the demographics of the United States have changed. To be a competent physician is to know and understand how these phenotypic variations affect the diagnosis and treatment of different skin diseases and the prevalence and incidence of different skin diseases. When we think of laser and light-based technology, often these are not covered by insurance in what's considered aesthetic dermatology. I sit at the table with companies and nonprofit or for-profit institutions and let them know that, hey, this is good for business. And they know that, so they're motivated. We've seen an advancement in dermatology embracing things that more people can use safely and effectively because they recognize that there is financial value in it.
I'd like to shift gears now and focus on medical management. When we think about conditions like acne, eczema, and psoriasis, there have been some important advances in both pharmacological and device-based therapies in recent years. Can you walk us through what the most significant updates in how we treat these common conditions? And what should clinicians be paying closer attention to that might change the way they approach management today?
We can start with acne, which is extraordinarily common and is caused by 4 specific factors, which is how the keratinocytes come out of the hair follicle. When they don't come out normally, they create what's called a little comedone or microcomedone. You also have increased sebum production, which is why we see acne, particularly around the time where people hit puberty because they have an upregulation on sebum production because of hormones. There's also proliferation of bacteria, P. acnes bacteria, and that combination together increases inflammation. We are aware now that in specific types of people, the inflammation is deeper, and so they're more likely to get scarring as a result of their acne. We see this particularly in Asians and African Americans and Hispanics. We see a lot more of those patients who have acne scarring as a sequelae to their acne. Isotretinoin is still the mainstay of therapy for the treatment of acne, but there's been a major advancement in the development of 1726 nanometer lasers that specifically target sebaceous glands and have FDA clearance for the long-term reduction in inflammatory acne. They have a 70% reduction at 6 months after a series of treatments. While it's an amazing drug, it is highly regulated, so this advancement in acne treatment is a big game changer. When looking at eczema, I think biologics are also a big game changer. Dupilumab, it's a dual inhibitor of IL-4 and IL-13, and these are the 2 drivers of inflammation. We're even using it in conditions like bullous pemphigoid. And there's more and more data that these biologics, particularly dupilumab, are advancing the treatment of a lot of skin ailments. Psoriasis has often been at the forefront because it is one of those quality of life conditions. And we know that TNF alpha inhibitors have been the biologic mainstays for the treatment of psoriasis and also psoriatic arthritis. Their newer interleukin 17, 12, 23s have also changed the game in psoriasis. Interestingly, GLP-1 agonists have also changed the game in psoriasis. So we know that there is a significant comorbidity of psoriasis and coronary artery disease. And oftentimes we will tell patients to change exercise or change their diet, and those things are really hard to affect the level of patients' weight. But we know with these GLP-1 drugs that patients do have a reduction in their total body surface area and psoriasis severity. For non-dermatologists out there, it is important to understand this cardiometabolic effects with psoriasis. So if you see a patient that has psoriasis, consider asking and potentially doing workups to make sure they don't have hyperlipidemia or cardiovascular disease. And always refer to dermatologists because for quality of life issues in these patients, you can significantly improve them with the advances we have.
The way you connected pathophysiology to real-world disparities, like deeper inflammation leading to more scarring in patients with skin of color, is an essential context for tailoring treatment. And these new modalities, from biologics like dupilumab to 1726 nanometer lasers, seem to be offering more targeted, long-lasting options. The evolution does sound exciting, but it also raises an important question. How well do these advances hold up across diverse skin types? Are there therapies you've seen that are especially well suited or perhaps poorly suited for patients with richly pigmented skin?
A lot of the data shows that when diagnosed appropriately and at an early stage, patients of color do well. We know that for things like cardiometabolic disease, it is more common in certain subtypes of patients. It's even more important for early referral and early access to care for those patients.
What's one common misdiagnosis you see often in patients with skin of color, and how can frontline clinicians avoid it?
Although melanoma is only 1% of skin cancers, has the highest mortality. We know when diagnosed early, the 5-year survival for patients is 94%. But when you look at African Americans, when they're diagnosed with melanoma, they have a 70% 5-year survival, which is really significant. We as physicians have to look at the science and the outcomes to tailor our treatments to give the optimal results for our patients.
That disparity in melanoma outcomes is striking and sobering. The fact that early detection so dramatically improves survival, yet Black patients are often diagnosed later, really emphasizes how much we need to expand our diagnostic lens. It's not just about teaching people to look in the right places like palms and soles and nail beds, but it's also about addressing the assumptions that lead to delayed care in the first place. You've been deeply involved in efforts to advance equity in dermatology. How do you balance the use of standardized treatment protocols with the need to deliver culturally and phenotypically informed personalized care?
We're really fortunate to be at Stanford, where precision care is one of our core values. This is a basic principle of healthcare, right? Do no harm and then do good, beneficence and non malfeasance. It's important to be able to deliver personalized treatment. If I see a patient, for example, who has a hair condition, and I know, having done a skin of color fellowship, I can't give the patient a shampoo and say, wash your hair every day with this, because they don't wash their hair every day. I can't tell you how far it goes with a patient who comes in who has phenotypically different hair for me to be able to ask them, how often do you wash your hair? What do you use to wash your hair? That improves patient compliance and patient outcomes. We can't do more in delivering that personalized care that looks at all of the variabilities in the patient, what we see phenotypically, what they do culturally, what they do every day in and out to deliver good health care.
I value how you bring it back to foundational ethics, do no harm and beneficence as the anchor for precision care. What I hear in your approach is that personalized dermatology isn't about abandoning clinical standards, it's about applying them with nuance, whether it's hair care routines, cultural practices, or how skin responds to light or inflammation. It all matters. And the outcome isn't just better compliance, it's better care, lower costs, and more trust. That principle feels especially important as we introduce emerging technologies into our practices. One of your core areas of expertise is fractional lasers for scar remodeling. Could you take us a little deeper into what's happening at the cellular level and how that understanding informs how you use these tools clinically?
You'll have to stop me because I love talking about lasers. But when we think as a light photobiologist, there are a few different ways that light can interact with tissue. At moderate levels, you can cause controlled destruction. At low levels, you actually stimulate biological functions. We know that people are using a lot of photobiomodulation or these red light therapies to stimulate biological functions. When we look at fractional lasers, we particularly look at those when we target water. We use what's called selective photothermolysis when we target tissue. So we look at things that will absorb wavelengths of light. And so the main chromophores in the skin are melanin. That's why it's so important to be able to know the patient's melanin and how their skin will respond to light-based technologies. With fractional lasers, they differ from traditional lasers that target water in that they have controlled tissue injury in microscopic areas with lots of normal skin around the areas. Anytime you have controlled tissue injury, which is often what we're doing with lasers, we want to spare some tissue for rapid healing and to reduce the incidence of side effects like skin burns that can lead to blistering, hyperpigmentation, or even permanent loss of pigmentation, which we can see really in all skin types. Fractional lasers revolutionize that. We use laser and light to either vaporize or to coagulate small microscopic thermal zones of tissue. What happens when you do this is the skin responds to tissue damage by upregulating things like heat shock proteins, particularly 47 and 70, lead to the production of collagen. And then the other thing that happens is you have upregulation of some matrix metalloproteases as the skin heals. During that process, you get upregulation of both collagen 1 and collagen 3. What's interesting about those ratios of those two collagens is that when we're very young or in regular adulthood, the ratio of collagen 1 to collagen 3 is about the same. As we age, our collagen 1 goes down and our collagen 3 production goes up. What's interesting with fractional lasers is they cause upregulation in both of those. The skin looks better because it's functioning like younger skin. We know when we upregulate that collagen production, we're creating normal collagen where you had abnormal collagen in scarring. So you still have collagen in scars, whether they're atrophic, hypertrophic, or keloidal scars, but that collagen is not normal collagen. Fractional lasers help create normal collagen through those microscopic zones of tissue injury.
What stands out in your explanation is how fractional lasers operate at a regenerative level, not just correcting the surface, but actually prompting biological healing. The idea that controlled microinjury can stimulate collagen production and restore the skin's architecture reframes laser treatment as cellular therapy and not just cosmetic enhancement. Red and blue light therapies are everywhere right now. Masks, at-home panels, you name it. And it feels like every skincare company is marketing some kind of light-based solution. From your perspective, where does the evidence actually support red light therapy, and where should we be a little bit more skeptical about what's being promised?
At these very low levels, you stimulate biological functions. We know that specific wavelengths of red light target what's called cytochrome C oxidase, which is what we have to build ATP in our mitochondria. Through inflammation and reactive oxygen species, we basically displace the oxygen in cytochrome C oxidase. What happens is that with red light, you can remove that and increase ATP production so the cells can function better. Red light is most studied in hair growth stimulation, where there is a lot of science, and we see an upregulation of insulin-like growth factor. We see effects similar to the application of topical minoxidil with red light therapy. So yes, there is science. Now, red light therapy can be delivered through laser, or it can also be delivered through light-emitting diodes. Laser is coherent light that is one wavelength, so it can travel long distances without losing a lot of its energy. When we go to things like LEDs, one is they're less expensive to make, and so that makes it more accessible. We want to democratize technology, but it's important to know that with those light-emitting diodes, that light can scatter. So if you're using it to stimulate hair growth, you want something that's going to separate the hair and deliver the light into the scalp. There are things that are in development where we can make sure that light doesn't scatter, which is a long way to say that there is real science behind it and there are clinical uses for it.
That was super helpful, and I appreciate the bit of myth busting. I'll admit part of that was personal curiosity. I do own one of those red light therapy masks, and I've definitely wondered if it was more hype than help. But shifting gears a bit, I'd love to come back to something you touched on earlier about aging skin. In your experience, what are some of the changes clinicians often chalk up to normal aging that actually deserve more clinical attention? And what should we be looking out for instead?
I'm very fortunate to have taken care of veterans for a number of years. So I see people who are in their 80s, 90s, centenarians. We know that skin, being the largest organ, serves many important functions. One, it's the physical barrier between us and our environment. We know that skin frailty can cause tears in the skin, which can increase infection. The skin is responsible for vitamin D production, looking at also thermoregulation. Evaporative skin cooling is a major way that we are able to regulate our temperature. Those functions decline with age, There are ways that we can optimize that skin to not have that reduction in function. When some patients say to me, getting old really is terrible, Dr. Rahman, I'll say it's better than the alternative. For countries with the level of wealth that we have, it is a privilege to get older, but your skin doesn't have to get older. I'm working with one of my colleagues, Dr. Ann Chang, to develop a validated skin frailty score that we can provide to non-dermatologists. While a lot of these changes may seem like they are just how the skin looks, we have to recognize that the skin also has really important biological functions.
You raise such an important point. Skin changes in older adults are often brushed off as purely cosmetic when in fact they reflect deeper functional shifts that can impact everything from thermoregulation to infection risk. Having a tool like a skin frailty score in the hands of primary care providers could be a real game changer. With all that in mind, I'd love to hear your thoughts on skin longevity. We talk a lot about longevity in cardiology or oncology, but how do you define it in dermatology and why is it clinically meaningful?
When I think of skin longevity, I think of optimal function of the skin. Anything that restores the optimal function of the skin to the levels of what we have in mid adulthood. Longevity has a better connotation than aging because people are living longer. It's going to be important for all of us to be able to work for a long time. I realize seeing patients who are coming in for laser light based treatments or neuromodulators in their 20s and seeing people who are centenarians and near centenarians at the VA that I've been treating skin longevity for a long time.
That's a refreshing way to think about it, framing skin longevity not around aging or decline, but really around maintaining function and vitality. It's so true that as people live and work longer, keeping our skin healthy becomes part of staying independent and resilient, not just looking good. Thinking about that idea of optimizing function, especially as the skin changes over time, what practices or interventions do you think hold the most promise for supporting long term skin health?
My top three are one, sun protection. A little trick that dermatologists use, which other clinicians listening can use, is patients are more motivated to use sunscreen to prevent premature aging of their skin than to prevent sun related skin cancer. I'm not telling people to go live in a cave. You still can get sun, but doing it in a way that's safer. So, sun protection. We know that retinoids have a significant role in improved skin functioning because they target many cells in the skin, whether they're fibroblasts or melanocytes or keratinocytes. They have lots of benefits. Then the third one, turns out that eating foods that are high in beta carotene, which is a vitamin A derivative, actually makes our skin look more attractive because it's functioning better. There's this 2014 study where they took photos of people and they made them more carotenoid and they had people evaluate their attractiveness. And it turned out that the carotenoid faces were viewed as more attractive. So there's something that happens in our psychology that shows us that when someone's skin is better overall, that's a reflection of their overall health, why we'd see them as being more attractive. So eat foods that are carrots, spinach, tomatoes, sweet potatoes, broccoli, squash, cantaloupe, and other green leafy vegetables.
I find it really exciting how our understanding of skin health is becoming so much more holistic. It's not just about topical treatments or photoprotection anymore, but how things like nutrition and lifestyle fit into the bigger picture. What really stood out to me in what you said is this idea of reframing prevention, not just as avoiding disease, but as promoting overall health, confidence, and long term function. So, as someone who really sits at the crossroads of academia, innovation, and clinical care, I'm curious, what are you most excited about when you think about the future of dermatology?
I'm most excited about technological advances in dermatology. I would say the shift to prevention and overall health with skin longevity, the use of advanced technologies to improve care. So, the use of lasers, energy based devices, neuromodulators, artificial intelligence used intelligently by healthcare providers. Shifting the mindset for those of us who have been trained in traditional medicine to integrate overall health for our patients with the change of prevention and looking at longevity, that's something that would resonate with our patients and motivate our patients to do things that are better for their health overall. Your skin has no expiration date. As long as you're alive, your skin has the ability to improve.
Dr. Rahman, thank you for coming on the podcast and for this incredibly rich and wide-ranging conversation. You've given us not only clinical insights, but also a deeper understanding of how dermatology sits at the intersection of science and technology and human dignity. From lasers to biologics to the ethical application of AI, you've helped us see that skin health is really about so much more than what's visible. It's about vitality, longevity, and equity. So thank you so much for your time today. This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.